I'm going to ask Martina to introduce herself before she started.
Okay.
Go ahead, Martina.
Yes, good afternoon, everyone. I hope you can hear me well. My name is Martina Penazzato, and I'm the pediatric HIV lead in the HIV, hepatitis, and STI department in HQ Geneva. In my work, I lead the drug optimization work for children, and more recently, also for pregnant lactating women. So I'm very grateful to the organizer for the opportunity to contribute with a short intervention on behalf of WHO in this important session. I think Dr. Lockman has really very eloquently provided an overview of what the issues are and offered a number of solutions for discussion. But I think she's made a very strong point around the important shifts that need to occur in our mind and really moving towards considering a better way to protect pregnant and lactating women through research rather than from research. And I'm sure you've heard this statement before, and you will hear it again and again, because this is really a key principle that we all want to promote through this conversation. I think that in WHO, we see this important topic as a cornerstone of our work in drug optimization and in reaching the elimination of vertical transmission. And in our work, we've learned that in complex topics like using ARVs for children or in pregnant lactating women, it's important to focus. So I want to echo the point made already by Dr. Lockman in the need to really identify what are the key characteristics of drugs that need to be prioritized and investigated first in this specific population. In our work, we've also learned how challenging the status quo is very important, and reviewing critically the way to really innovate the way our approach to clinical trials, in particular those that enable approval of new drugs in adults. It's very, very important. And we know that these need to happen within the context of a appropriate ethical framework as well as a thorough scientific discussion. And we need to really be able to explore innovative approaches and methodologies to optimize the opportunities to generate data in this critical population. Obviously, these require multiple stakeholders to work together, and we in WHO are very committed to convene that dialogue together with others and ensure that this conversation is closely linked to our normative work and that it can be translated to other disease areas as soon as possible, since so many really are affected by the same challenges. We are partnering in particular with the Impact Network and IAS to enable a scientific discussion, a thorough scientific discussion with the first, and a broader engagement with industry with the second. And we really want to build on this current momentum because we think that there is a critical mass of experts that are really converging around some key principles. And we want to make sure that we can add granularity to the best way to really move this agenda forward. So we hope that this workshop today really will be another step in our journey to generate better data for use of new drugs in pregnant lactating women. And we've already heard about a survey that will be really the tool for us to get your input and your perspective, and we hope really to be able to use it and to help us to advance more concretely in this work. So I'll stop there just to confirm again that WHO is very committed to this agenda, and we're really very keen to work with all of you, and in particular with some of the partners that are represented in the room. And I'll just hand over to the panel to discuss in more detail some of the technical issues. Thank you very much.
Thanks, Martina. And we know it's quite late for you. So I thought we'd start. I want to introduce myself. I'm Lien Abrams from Columbia University, and have a long history actually working with many people in this room and in this panel, and backed my way into maternal health through the kids, starting off, taking care of kids with HIV infection, and then becoming, over time, a very loud advocate for healthy and strong treatment of women. So I'd like to go next and ask Lynn and Kathleen to introduce yourselves.
Do you want comments at the same time, or?
No.
Okay.
Just introduce yourself and then.
Hi, I'm Lynn. I'm Lynn Moffinson, former worked at NIH, and now I am a senior technical advisor to the Elizabeth Glaser Pediatric AIDS Foundation.
Hi, I'm Kathleen Squires. I'm at Merck. I've been there for about 2.5 years, and I'm the global director for HIV Scientific Affairs. And one of my major tasks is to run what we call the Merck Investigator-Initiated Program, which is essentially a phase 4 program. So, hello.
Shahin, do you want to tell people who you are? I know.
I'm Shahin Lockman. I've been working in Botswana with some of the colleagues who are in this room I actually started working there 23 years. I'm actually an adult internist and ID doctor and have no business working in OBGYN or pediatrics, but that's what I've been doing for a long time.
Okay. So I think we sort of want to do 3 things. We have some questions, but also I'd like to maybe start with some comments, and then we really would like to hear from people in the audience, even though it's late on Friday. So, Lynn, you have something you want to start with?
Just a few comments. I feel like I've been arguing about this for 25 years, forever, but I was preparing a talk for a TB meeting, and I realized what Shahin said is really true, that we are on the forefront of HIV. INH was approved in 1953. The first PK data on INH was last year, 2000 in pregnant women, 2019. That's a 66-year delay. And what did the 2 studies show? It showed that the levels of INH are low during pregnancy. So actually, looking back, I feel much better about what we've done. There's a whole bunch of things I wanted to say, but let me just say one, which is that it's use of drugs in women of childbearing potential, because women of childbearing potential get pregnant. And that while we need to get the animal data to be able to get the PK data, to be able to get some safety data, it's important to recognize that for low prevalence events like birth defects, you really need very large numbers, and you're only going to get that with post-marketing good pharmacovigilance. So for example, for a birth defect like neural tube defects with a prevalence of, say, 0.1%, you need over 2,000 preconception exposures to be able to rule out a 3-fold increase in prevalence. So that we're still kind of stuck, that we're going to have good post-marketing pharmacovigilance data. So how do you get that? Well, the Antiretroviral Pregnancy Registry, I think I spoke here a couple of years ago, and argue for everybody, please report your patients to the Antiretroviral Pregnancy Registry, because that's one way we get good pharmacovigilance data. And the second way is to support studies like the study in Botswana that showed us the potential association of neural tube defects with dolutegravir. And so I'll stop preaching with that.
Do you have some comments?
Yes, please, Kathleen.
Well, as I said, I've been at Merck for 2.5 years, so I wasn't brought up in the drug industry. But before I joined, I was a clinical investigator and a clinician and faced all the same issues that we're talking about here. I mean, I do think that what I have experienced since I've joined Merck is that the updated FDA guidance, I think, has provided kind of an impetus and really a foundation for individuals within industry who are interested in kind of moving this research platform forward, so they have something to go back to. And I think you find, like in anything else in life, people believe that certain things are truisms, and one truism is that you have to protect a pregnant woman, and by by virtue of that, you are protecting the unborn fetus. And I think trying to get people to realize that you are almost, and now this is me speaking, not Merck or whatever, you're almost treating a woman as a second-class citizen in that situation doesn't occur to people. And when you try and put that into context, some people get an aha moment. So I won't belabor the point at the moment. I will say that at Merck we're embarking on a phase 3 program with one of our experimental agents is islatravir in combination with doravirine. And we are really trying to be very proactive about how to handle pregnancy in the phase 3 studies, and I can spend more time talking about that.
Well, maybe I could ask you, it doesn't have to be specifically about that study, but what kind of innovations do you see needed to move this agenda forward, and also to move forward the dialogue between the scientists, the community, and industry? Because it does seem like there's a moment where we can start talking together to accelerate this. Yeah.
So, I mean, I certainly think some of the things that are ongoing, like the CIPHER program, is very good. There was a meeting last June, where many of us here participated in that, and that is a forum that really facilitates those kinds of discussions. And I think that is prodding people, especially in industry, to reconsider, what they are doing. I guess that, to me, that would be one of the major ways is to kind of put people's feet to the fire just a little bit, and realize that the FDA guidance, again, is not a mandate, but it is something that I think companies really have to pay attention to, and the feeling that they have to explain if they're not going to do the recommendations in terms of the phase 2 and the phase 3 studies, they need to explain why. What is it that would stop them from doing that?
Dr. Moffinson, thinking back to before you retired, when you were designing and funding trials, do you have any thoughts on characteristics of a drug that we might focus on or target that would make them more desirable to study during pregnancy? We don't necessarily want to study every drug, right? And how do you go about just thinking about that?
So, the first thing that you need to be able to study the drug is the preclinical reproductive toxicity data. So right now, you don't have to get that until near the end of the phase 3 trial. So in order to be able to move studies back, you need to get that data during the phase 2B process so that you can then do the pharmacokinetic study, which you cannot do unless you have that reprotox data. So ideally, what you'd have is no animal problems on reprotox. That would be the ideal agent to be able to say, okay, let's move forward. There was something else I was going to say. Oh, I know what I was going to say, which is the issue is for antiretroviral drugs, if a drug is approved and it's going to be used for treatment, it's going to be used for treatment of everybody, men and women, okay? So if it's used in women, and in HIV, 50% of the infected individuals or more are women, and most of them are of childbearing potential. So to me, that means you have to do these studies in all drugs that are going to be put into the general population, because you're not going to take a drug and say, okay, here's this really good HIV drug and only men can get it. So if you have to have that data, then you have to have it done on every new promising drug, unless there is data from the reprotox stuff that says this is going to be bad.
Lynn, do you want to comment on that, on the drug characteristic?
I mean, I certainly agree. The issue that is most germane to HIV infection is that over 50% of the population are women, And the vast majority of those women are women of childbearing potential. So there's just that tight interplay between a woman and potential pregnancy. And to not have the data available, at least, I mean, as Lynn had pointed out, for conditions that are rare, and that for most of the, some of the toxicities that we're thinking about, you're never going to be able to see that signal in clinical trials. But at least you could have, you could inform about the use of the drugs in terms of the PK in pregnancy and safety. And to not have that data available at the time the drug is commercially available in a population that's over 50% women just doesn't make a lot of sense.
Shahin, in addition to addressing that, I was also going to ask if you might talk a little bit about communication and thinking about how we engage and speak within communities and particularly women. Yeah.
Thanks, Elaine. I just wanted to, also going back to this question about how to prioritize drugs, I think a few points. One is for ARVs, we're thinking about prevention as well as treatment. And so for, young women are, as you articulated so well, are in greater need of good prevention than anyone else on this planet, probably. And so I guess the only thing I would say in addition is, I think eventually we want PK and safety and outcome data for all drugs that are being used by women of childbearing potential and pregnant women. And I think we probably, if we need to prioritize them, should prioritize those that have more than a small incremental improvement, either in safety or effectiveness or method of delivery in non-pregnant individuals. So for example, the long-acting agents. It's a no-brainer. We want to know, are these going to be safe in women for prevention and for treatment? I think I feel a little different, and are these drugs that are going to probably be used by large numbers of women throughout the world? Or is it a new drug that, overcomes drug resistance in people who, have multi-class virologic failure? Those things are easier. I think if it's a drug that has just a little bit of improvement or is slightly different than another drug, it may be possible to wait until the post-marketing arena for those, or at least they're lower priority. And I think these are the exact discussions we need to have and arrive at some kind of understanding of, some kind of general understanding. Mm-hmm. In terms of communication, I don't know how we're going to address this. I think this is one of the, we say this, but we have to really do it and mean it, where we need to work in lockstep with community every step of the way. The community of people who are affected and would use these drugs, or take care for people who use these drugs in the future. And I think one thing that I'm struggling with a little bit is that how do I say this? So I think, the neural tube defect finding obviously caused massive dismay and consternation, and it is a terrible, horrendous outcome, if it's more common with a certain medication. But children die. There's a stillbirth, neonatal death, all kinds of very, very bad outcomes that functionally result in loss of a pregnancy or a non-viable fetus that cannot be as clearly attributed to a drug and therefore go undetected, unreported. And this is where you need the research to show that. So I think the problem is, though, how it's a very emotional topic. People obviously, women, families are, it's a very tough topic to talk about, and we just think we need to think about ahead of time how we will convey. If we do these studies, we probably will find some good things and we'll find some tough things. And if you find something tough, it doesn't mean you never use any drugs during pregnancy. Again, you have to explain the downsides of not using them and quantify those. And so I think it's just going to require a lot of thought and a lot of consultation and planning, and ideally working with community for sure, and ideally working with health communications experts.
One might say this issue of infant death and poor outcomes is something that we don't talk about in general, but are only shining a light on because of the drugs. So we're going to have to deal with some difficult issues.
Absolutely. Right? So for example, nevirapine in Botswana, women conceiving on nevirapine, 6% stillbirth rate. Much, much higher than closer to 1%, which is still high in women without HIV.
Just a comment that we've been ignoring bad problems with antiretrovirals for a long time because we are afraid people won't take them. But as I think I said in my talk this morning, just taking antiretrovirals alone, even the, quote, good drugs like efavirenz and dolutegravir, although 10 years ago we didn't say efavirenz was a good drug, they still have an elevated rate of adverse pregnancy outcome compared to HIV uninfected women. So none of these drugs are without any problem. It's just the problem is we don't know how to discuss the problems without sounding like we're telling people don't take it, which we want them to do. So I don't know how to do that, but I just wanted to.
It's also about our expectation, and I don't think that's different for non-pregnant individuals. These are not there's no magic, and people have other diseases. There's not an expectation that there won't ever be side effects or adverse effects. So it's also embracing that. You expose a fetus to a drug, something's likely to happen. Okay, so I think you wanted to say something?
I just wanted to say one more point, and I really was impressed and want to bring to the highlight the Shahin data that women were lining up to go in the studies. And when I'm hearing about ARP, and I know that on the busy clinical side, reporting anything that's voluntary is always very challenging to do. So I wonder whether we have explored enough the voice of advocacy of pregnant women, especially here in the lining up, self-reported some form of registries. I mean, in the era of the media, could there be some kind of dialogue with women on creating and registering themselves as a pregnant woman living with HIV on the meds, and maybe giving some journal educational information? So just a question, and bringing another aspect to us at the table is that I don't know if we explored enough the voice of pregnant women and breastfeeding women, lactating women advocacy in pushing this topic forward. And I think that could be a very powerful tool. With that, I'd like to turn to the audience that can be also a very powerful tool. And we would like to really dedicate the remaining time to some of the comments from the room. And please, again, reminding you, this questionnaire is ongoing. It's about 10 questions. There's space to leave comments. If you don't have time, please, if you could devote a few minutes after, your feedback would be very valuable. Can we go back to the room?
Hi, Anton Pozniak. I just want to address this issue of drugs and adverse pregnancy outcomes, because I'd like to ask the panel how they'd untangled that from the issue that women with HIV are often very different demographically from women without HIV in terms of education, nutrition, food access, STDs, all other sorts of factors that roll in when you say, hey, it's more here than there. It's more in the HIV positive versus matched HIV negatives. I can see between drugs you might be able to do that, but I just wondered how you might unravel the fact that it's a drug-related issue rather than issues concerning their epidemiology, demography, etc.
I think just to answer for places where there are severe generalized epidemics, as in Southern Africa, people living with HIV are really not that different than people who are living without HIV. It's very different than here. And so it really is a generalized epidemic that affects every family. So I think that is much less of a problem in that kind of setting than it is here in terms of the study methodology. And there are other studies as well that have looked at pregnancy outcomes in earlier eras among women living with HIV who were not on combination ART during pregnancies, and then the PROMISE trial, comparing AZT versus combination ART. So I think those are the ways we can try to tease it apart. And I think untreated HIV is not good. And I think that to me the communication piece is it may be a risk, but the risk of not taking treatment is worse, and so we just have to make some decisions.
Want to make a comment before we go on?
Yeah, I was just going to agree with Shahin that I agree for studies done in resource-rich countries, you've got some big disparities, but in studies like Botswana, I'm very comfortable saying I believe that data.
I would say, as someone who works with women living with HIV during pregnancy in a resource-rich setting, yes, there are differences between the patient population that I take care of compared to the general population. but don't underestimate them. I talk to all my patients, regardless of whether or not it's about a research study, about the drugs that they're on, HIV as a condition, the fact that their pregnancy, although it's not high risk the same way, a patient that's on dialysis is high risk. It's high risk because we don't know about what additional risks may exist in terms of preterm delivery, in terms of low birth weight, in terms of XYZ. But that we do know that antiretroviral therapy is critically important, both for their health and the health of the baby. And they seem to accept that. And I've had very nuanced discussions with women about dolutegravir, whether or not they wanted to continue it in pregnancy. And these are women, some of whom have an 8th grade education, but if you talk to them on their level, honestly and clearly, I've actually been, now I've been doing this for, 8, 10 years, Nutella? I don't even know. But, at this point, if you meet people where they're at and you give them the information in a way that they can access and process and understand, despite the socioeconomic barriers and the multiple issues that these women face in their day-to-day life, I think we can't underestimate them and their ability to understand. And I'm currently working, as part of my K23, I'm working on a study looking at adherence benchmarks for tenofovir emtricitabine in pregnancy. Given that we don't know what the benchmarks would be for plasma or PBMC levels compared to a non-pregnant woman, secondary to the increase in GFR, plasma volume, et cetera. And the vast majority of my patients that can participate really want to because they want to contribute to the science. And they understand that although they know that this is one of the best medications we have, we don't know enough about it. And they, yes, there is a financial incentive, but the majority of them want to participate because they want to give back to the community of women that they are part of, despite the fact that a lot of them haven't openly disclosed their status and don't know other women that are like them, but they want to make health and healthcare better for women like them. So yes, there are differences, and yes, the care is different for this patient population in resource-rich settings, but it's not undoable, and I think there's a lot. I think it's not as hard as people make it out to be.
Thank you. Were there other questions?
I'll just echo her comments. If we get out of the way as researchers, scientists, and sometimes clinicians of women, they can make the right choice. Women made the choice in the very early 90s to take a drug that was not studied, that men were taking and dying. And they all enrolled in 076. What if we didn't give them that opportunity? Where would we be today? Let's get out of their way and let them participate in the clinical trials.
So I think much of what we are aiming to do is to increase the ability of women to participate and to have more trials earlier so that they have information in which to decide when and how to use these drugs. Great.
So I guess one other issue in the ARV world is it's such a moving target. And, yes, we've heard that, we want to use the drugs that we're recommending for everybody, but recognizing it takes time to build the cohort. And then by the time we do that, the field has moved on. And then I think that leads again for pregnant women to get the older drugs rather than some of the newer drugs. So I think the challenge is really doing that in real time in terms of kind of the soup du jour, which clearly changes a lot. As we've talked this morning, getting women in clinical trials is tough. My image of getting pregnant women in clinical trials is worse, but I'm very pleased to see how well you've done. And I think we need to really learn a lesson from that and why. What was the incentive that allowed so many women to participate in that trial, and can we learn from that to move our field?
I just wanted to make a comment. So the way you deal with this is by doing the studies before the drug is approved. What you're talking about is how do we prioritize this plethora of drugs that we already have? And I'm saying we shouldn't be in that situation. We should have the data before the drug is approved.
Number one there. So I'd just like to make a comment. Having worked with women for many years, often because of the fact that results in pregnancy are not known. Drugs are women aren't allowed to take the drugs in pregnancy. So it's been wonderful for me to now be able to prescribe dolutegravir to my women in Papua New Guinea and in the Pacific Islands, basically if they're pregnant, saying, look, you need to understand these are the options and these are the choices. We know if you take efavirenz, 25% of the population there are resistant to efavirenz. So you're giving women a very much a poorer choice. But this is the first time, and I would really commend WHO for having made that decision, that it's a case-by-case decision that needs to be discussed with women rather than making the decision for us.
I'll point out that one of the issues that held up the approval of dolutegravir as the preferred first line was the delay in having data in pregnancy.
I was wondering whether anyone on the panel or elsewhere could answer a question about the industry that's involved in the sorts of research and efforts that are going on. Of course, industry is absolutely essential, but I wonder if there is any either requirement or encouragement that industry that have an interest in or manufacture infant formula declare a conflict of interest when they're dealing with issues related to drugs and lactating women, since infant formula is, for all intents and purposes, a competitor with breast milk.
No.
I don't think so. I don't think there's that. I mean, studies in pregnancy are one thing. Studies during breastfeeding are also difficult in terms of getting people to look at it. So there's even less studies for antiretrovirals in breastfeeding than there are PK studies. So we're pretty far behind.
And I would think that the HIV-infected women market is not impressive in the resource-rich settings where most of the formula market is, and therefore will not be big financial drive for industry. And in resource-limited settings, the formula is much less relevant, and there is not much to compete for. So in U.S., we estimate 5,000 women living with HIV who are pregnant a year. This is not a sizable market for the country where they have so much more to sell.
One more comment is that I think it would help if the FDA put out some requirements on this, because if you go and you say, well, we should have pregnant women in phase 3 trials, and then you actually think about, well, how do you incorporate pregnant women into a phase 3 trial? They have adverse events that are different, that are already ongoing. There's already preterm delivery. How do you do that? You end up with a very complicated protocol, which is why when it's brought up to the adult internal medicine people who are designing trials, they say, oh no, I'm not going to do that. It's going to mean that the protocol takes a year more to get done, and then the IRBs won't approve it, and et cetera, et cetera. So how do we make it so that there's some more incentive for the companies, or make it easier for the companies to do these studies?
Or add innovative.
There's the issue of women who become pregnant in a clinical trial.
Yeah,
right.
yeah,
That's different. But at least if those women are allowed to, after being informed of all the pros and cons and what we know and what we don't know, at least you get some preliminary information about safety. And if there's a possibility of being able to offer them PK studies for sites that are able to do that, then you have some data at least to inform a decision by the time the drug is approved. But I think doing studies in pregnant women would require a separate study simply because of all of the issues that you pointed out. It could be a sub-study, right.
But even if you leave pregnant women on, you have to account for that in your
Yes,
sample size and
Right.
such, because they will no longer feed your endpoints in the same way. So it does require some fancy
discussion
footwork.
our statisticians have.
Yes.
Right.
And this will be the last, okay, we'll do two more, and then ask Martina if she wants to say some closing words.
Thank you. I just wanted to make a comment and then ask the panel a question. So Shahin, you were talking about how easy it was to recruit pregnant women to your study and you didn't have enough places. And I think actually, although women are very underrepresented in studies, where a study really interests a woman and a woman is involved, you know, a woman with that healthcare condition is involved in study design. So for example, in the UK, we have the PRIME study looking at perimenopause and menopause in women with HIV, the largest recruited groups, so 900 women. And women with HIV were involved in the study design. And I just think actually peer mentoring is also very active in the UK. And I just wanted to ask the group about their experience of community representatives being involved in research design to therefore produce a study that will inherently interest women, and therefore there will be community support for that study.
Yeah, go ahead.
So I think that's an incredibly important point, and I think that is becoming more and more the norm. This particular study was a impact network study, so it was done at multiple sites, or impact sites throughout the world, and each of those sites works with community advisory boards and community groups, and their community representatives on the protocol concept and then the protocol development team. And I think all of that definitely helps, especially bringing together people who've done this kind of work for a long time and have a sense. But I think there are some protocols that are important to do and difficult to enroll to, and doesn't mean they're not important. But where possible, I think that these kinds of studies really are attractive to women and have been shown to be. These are women who are entering voluntarily, and it's not for the financial incentives. Yeah.
Where's that last one? Yeah.
Yeah, I need an easy take-home message, I think. I don't know, because of the jet lag, I can't sum it up. Did I get you right? Our regulations are changing, so it will be easier in the near future to include pregnant women in clinical trials, or not to have to exclude them when they get pregnant in a clinical trial. So, looking at the treatment of pregnant women in Europe, looking at the latest guidelines and looking at my national guidelines, I see that we treat women of childbearing potential or women planning to get pregnant and pregnant women like kind of old-fashioned compared to young men. So when will this change? What do you think? How long will it take until these changes in regulations reach the clinical everyday life and will have an impact on the guidelines? That would be good to hear, or you can make a guess, I mean, just to motivate us to include the women in the trials.
Yeah. Well, I would say that if every person in this room goes back to their guidelines groups and their work, and we're all starting to think about this differently, that it's going to happen faster than, right?
It's
years before it happens, but we're already beginning to see more conversation and more interest.
But if you all fulfill the survey with very strong appointments, we are going to do a position paper that's going to help to move it forward.
So, my name is Vani Vanapagari. I'm head of epidemiology at Beeb Healthcare, and I do quite a bit of pregnancy studies, as do a number of my colleagues. We generate reproductive toxicology data usually before phase 1 studies start. If not, by the time phase 2 studies start, we have that in place. We are now at Weave, we are making a concerted effort to publish those data. Those reprotox data have always been present. It's just the publication of that has been lagging. So if you guys have noticed, our long-acting injectable cabotegravir, it's not approved yet, but there are 2 posters, one on the PK tail in the pregnancy. So there is a little bit of PK tail from the clinical trials, and then there is the reproductive toxicology data. So there are 2 posters. That drug isn't approved yet. There's another drug, fostemsavir, that we have already gathered. Whatever data we have from clinical trials, we have already submitted to IIS. So I think we are trying to reduce that 6-year lag time to less than that. The other thing I do want to say is, for us, it is important to generate the data in pregnancy, but we are constrained by many things that you guys have eloquently pointed out. We are making a concerted effort in many of those areas where we can increase data generation rapidly. So partnering with the networks is one way of doing it, and you guys know how long these studies take. So we are part of many of the network studies. So even for dolutegravir, we had, long before the NTD issue came up, we had the antiretroviral pregnancy registry, we had set up Dolomite program. So it's not that we don't have this especially within my community of the very strong women researchers within Weave. We do plan proactively to do this. It takes a lot of time. That's one of the things, but we're trying to improve the situation. But please do visit. Both the posters are up there, so you can see the long-acting injectable, at least some data in pregnancy. Thank you.
Okay. I think we'll bring this to a close. Martina, are you still on?
Yes, I'm still here.
Would you like to make any final comments before we thank everyone?
Well, just to say that I'm very glad that point was made around engagement of the community really in the way we undertake research in this area, and the importance of involving women early on in this thinking. I think it's something that we definitely want to emphasize from our side. And then I've heard a number of viewpoints that I don't think necessarily had emerged in previous conversations, so I'm hopeful that the survey will give us a chance to expand further our thinking and to refine some of the details of it. So really looking forward to work with many of you in the rooms in the next months to come.
Great. Well, thank you for staying up. Thank you to the panelists. It's an interesting conversation, and thank you to everyone for staying till the end of the day to take part in this.